Yesterday itself, I told you, before starting any movements in the upper limb, now also I told you, I have taught upper limb movements yesterday, but I have left only one small portion. I will teach you like that I told you. That one is scapula. So before doing any kind of movements, whether it is elbow or whatever, especially in shoulder, when you are doing any kind of movement, flexion or abduction or whatever it may be, you think of one thing. Scapula is fixed over here. Already the scapula must be in 30-degree plane with the thoracic region. When the patient is lying like this, it is already fixed with the bed and it is compressed. So it is already retracted. And most of the people in this position, they look at here, can you see? Look at here, the shoulder is shrunk a little bit. I'll show you the difference now. You may think that this is right. Just look at this. It is dropping, right? How far the difference was there? And here also. Can you see the difference? How far the difference is there? Right? This is one thing. After doing such things, can you observe a little bit change in the shoulder, the height of the shoulder? That is because the shoulder has realigned in such a way, that means the shoulder blade, scapula has realigned in such a way that it has come to the proper movement preposition for scaption. Okay, so the scapula is now ready. Now we are going to start the movement. But when I'm going to make the movement, the scapula is going to restrict because of the pressure, the load between the body weight as well as the weight. How we are going to reduce it? Suppose, imagine, body weight is there, scapula is there, and weight is there. It is going to compress like this. So it will not make it move. It is not simple for him. I am speaking about the patient, especially the hemiplegic patient, the flaccid patient. When you are going to move, it will be fixed, and when you are going to move like this, the soft tissues around this, especially the capsule around this, the ligaments around this, plus importantly, teres minor, major, latissimus dorsi, all these muscles will go for impingement. Right? So it should not happen. I told you already, if these things are happening, definitely it will cause shoulder arm syndrome. It is not easy for him to recover. It may cause shoulder drop also. It is not easy for him to treat. Okay, it will cause so much of pain. The movement pattern will be wrong. So the recovery will be so delayed. So okay, sir, what we shall do for this? I'm going to do some arrangement in scapula, do some mobilization in the scapula, so that what I'm going to do is I'm going to use some better fluidity for this scapula. If the scapula is moving finely with fine lubrication, suppose imagine you are putting some oil at the two-wheeler. Likewise, the same way, I'm going to mobilize the scapula in such a way so that it will be so smooth and free. It will move smoothly. Afterwards, I will go for shoulder movements. Then it will be fine. Okay, that's what I'm going to show you now. Before doing any kind of shoulder movements, you are going to do this. Okay, for that, I'm going to make the patient to rotate to this side like this. Yes, can you rotate? Down to this side. Suppose this side is affected. Okay, I'm going to place it like this, and I have to help the shoulder. Help the arm like this, and he is going to rotate like this. Now I'll support here and turn. Okay, make the patient to be positioned in such a way like this. He has to be so relaxed in this position, side-leg position, and he needs some support for head also, like this. Okay, now he is fine. We can put the right arm or which is under the body now, this side, that hand under the pillow. It is so supportive and helpful. Okay, we can make the patient's hand like this initially. What I'm going to do now is I'm going to make some space for me to stand here. Okay, in this position, I'm going to put the patient's hand like this. Put it like this. I'm going to raise the scapula like this. In this position, I should be so close. Okay, this is spine of the scapula, right? This is what is the process? Acromion process. This is medial border of the scapula. This is lateral border of the scapula. This is lateral border of the scapula. This is medial border of the scapula. I'm going to grasp it entirely like this. Plus, I'm going to trace the scapula, spine of the scapula in one side, and both the medial and the lateral borders on another side. This hand will be holding the medial and lateral borders. This hand will be holding, approximately holding the spine of the scapula like this, right? Now, I'm going to mobilize the scapula this way. And retraction. Partially, it is protraction and retraction. Actually, protraction means it will come like this. Normally speaking, scapula is hiking. The scapula is dropping. So this is scapula hiking and dropping. Scapula hiking and dropping. Right? This is partially. So what partially means? It is going to combine with the lateral movements of, lateral deviation of the scapula. What is that movement? This is protraction. This is retraction, right? Protraction, retraction, protraction, retraction, protraction, retraction. This one is elevation or hiking. This one is depression or dropping. So elevation or hiking of scapula, depression or dropping of scapula. This is protraction. This is retraction of scapula. You make such movements. Some 10 movements like this, some 10 movements like this. It will produce nice mobilization for the scapula, right? And then lead the patient. Now, you lead the patient and making him normal position. Okay, can you turn around that way? Yes. Face up position. Yes, right. Now I am placing the patient in such a way he will be so comfort. Wherever it is necessary, I will place the pillow. Now I am going to move the upper limb, the shoulder. What are maybe the movements? Where it is abduction, where it is flexion or extension, what are maybe the movements? I have prepared the shoulder to do in such a way so that it will not go wrong. Now the scapula is fine. Now, for example, I am producing some flexion movement. That understand the scapula will be nicely mobilizing in this way. It will be cooperating with the upper leg entirely. That means the humerus. So that the scapula thoracic movement will be fine. So that the scapulohumeral rhythm will be maintained. That is very important to make the movement without any impingements of the soft tissues. Okay, I am making such a movement. Suppose if I am not doing anything like this and I am doing the movement, for example, flexion means there will be impingement here.